Over the past 20 years or so, there's been so much progress in radiation oncology. For those who have been at the conference today, we've heard a lot about it already. But just to say that I didn't know Mark when Adam was unwell 10 years ago, and now I know him so well. You know, radiotherapy is on the map, and we're going to hear a lot more about it. It's become a vital component of treatment for many children, adolescents, and young adults with cancer. Dr. Carolyn Freeman has been central to this advance over the last 20 years and is particularly recognised for her work with children. Professor of Oncology and Paediatrics at McGill University in Montreal, with over 30 years' experience, she has recently been elected to the Board of Directors of the College of Physicians of Quebec. Who better to offer our second annual lecture? Carolyn, we very much look forward to hearing you this evening. Please welcome Carolyn Freeman.
Thank you very much. So I want to say thank you for inviting me to this great day. I think it was a wonderful day, actually. It was very interesting, and it was very interesting to see the interactions that were taking place. Thank you for choosing radiation oncology as the topic for this year's Adam Hay lecture. I think I agree with you completely that we're often not involved enough at the beginning, or we're not as present as we might be at the beginning with a new diagnosis. Thank you too to Susan for sending me pictures of Adam, and to both Susan and Mark Gaze for helping me think a little bit about what I would talk about today, because in fact I wasn't given a title, actually. So I had to make up my own talk, and I hope it's what you want. Really, it's about the changing role of radiotherapy in the care of children and adolescents with cancer. And the problem, in fact, so many of the talks today have said some of the things that I'm going to say today, but you heard this too. Radiotherapy has a bad reputation because of long-term side effects. Cosmetic changes such as permanent hair loss, effects on growth and development, effects on learning, and the development of secondary cancers as well. And it's a fact that, in fact, the concern about the development of, the risk of development of adverse events has led and leads to significant variations in radiotherapy practice, the use of radiotherapy, depending on philosophy. And you heard some of that today, too. But there is good news, and there has been major progress in radiation oncology over the past 2 decades. And most of this has been specific. A lot of it's technological, but the potential is clearly to either maintain or improve local tumor control and or reduce the risk of side effects. And so my plan today is to tell you about the changes that have taken place over the last little while, and developments that may have implications for the future. And along the way, too, I'm going to talk about or touch on the importance of clinical trials, and also on the question of competing risks and how do you make decisions with respect to treatment. And again, this is not an easy problem in pediatrics, and we heard about that today. So cancer in children is not frequent, but it is an important problem. It's about, these are UK data in 2011. We're talking about approximately 4 new patients diagnosed each day of the year. It is the leading cause of death due to disease in children in the 1 to 14 age group, about 20% of all deaths. But it's also a success story, because the survival rates have more than doubled since the 1960s. In the 1960s, survival rates, again, you've seen some of these data today already in different formats, but the survival rates in the 60s were not better than about 30%, and now the UK is close to 80%, and in the US and Canada, the 5-year survival is now greater than 80%. And this is due to many different factors. There have certainly been improvements in diagnosis, in imaging, in pathology and molecular diagnostics. There are certainly improved treatment in surgery. You saw some of that today, perioperative care, in radiotherapy that I'm going to talk about, and in chemotherapy. We're much better at providing necessary supportive care, whether it's hematologic, nutritional, psychosocial, or any other form of supportive care. And most especially, I would say, we're better at integrating all of the needed treatments into the therapeutic plan. And this has been in very large part due to the role of the national and international clinical trials groups. The result is that we now have large numbers of survivors. In the US, the estimated number of deaths averted from 75 to 2006 is 38,000 plus. In the UK, the total number of survivors is estimated at around 26,000. And the problem is that the health of survivors is not necessarily good. These are data from the Children's Cancer Survivor Study in the United States, and these are clearly patients. We're talking about patients followed for some 20 to 30 years, so they were treated, in other words, 20 to 30 years ago, and with different techniques, different approaches to the ones that we use now. But the fact of the matter is that 2/3 of patients have at least one chronic health problem, and about almost a third have a severe or life-threatening one. And the frequency increases over time with no plateau. Radiotherapy is an important factor, but it's not the only risk factor. There are late effects due to the effects of the tumor itself and the effects of other treatments, such as surgery or chemotherapy. And there's certainly an individual susceptibility that we don't know enough about at this time, whether it's genetic or environmental or other. But radiotherapy is a very effective treatment. It's known to be a very effective treatment, an essential component of treatment, in fact, for many patients that can be shown to be associated with improved local control, improved progression-free, and overall survival. So, as I said, there's been a lot of progress in pediatric radiotherapy and radiotherapy in general, but in pediatric radiotherapy, along with improved overall treatments, we have made significant changes in practice and have refined indications for treatment with radiotherapy. These are some population-based data from the United States, given to me by Kenneth Roberts from Yale University. These are unpublished data, but they show what they show, and this is mirrored other countries, and there are published data that show similar findings, but they show clearly a decline in usage in some diseases. A classical example would be patients with acute lymphoblastic leukemia, where you see as a result of better chemotherapy and improved survival, continually improving survival, we now find that only 10% of patients need treatment with radiotherapy, and in fact it's probably even a little bit less than that now. In brain tumors, too, there's been a significant decrease in the use of radiotherapy. This is due to earlier presentation of disease, better understanding of the biology and the course of the various tumor types, and, as we heard this morning, better surgery, including the use of intraoperative MRI. And this has resulted in a higher frequency of complete resection of tumors than was possible in the past. And this is a very good example. Actually, this is a patient who was referred to me from another center in Quebec for treatment of this thalamic tumor. In other words, treatment with radiotherapy. But this, in fact, and in the past, this patient would have been treated with radiotherapy. But in fact, surgery is now possible for tumors like this, and this is what this patient had for treatment, and has done very well. He had no sequelae from the surgery, and of course he didn't have any adjuvant treatment, either chemotherapy or radiotherapy, and can be expected to do extremely well. But there's a very high probability that he will not recur and not need additional treatment in the future. So treatment has changed significantly. Improved overall treatments have also led to significant changes in radiotherapy practice per se. Volume reductions, smaller volumes of tissue treated because of response to chemotherapy, and tailored treatments based on response to chemotherapy. And there have been dose reductions too in response to tailored to response to chemotherapy. And Hodgkin's disease is an excellent example, where event-free survival and overall survival remains extremely high, even when radiotherapy is not used. So, in other words, as in the past, patients might have got radiotherapy alone or a chemotherapy combined with radiotherapy. Now, on the more recent studies, this is the German data, but the data are very similar in North America, even without radiotherapy. So based on a very favorable early response to treatment, these patients do not receive radiotherapy. And results are excellent, as you can see there. There are a few more relapses, and this is something that needs to be discussed up front, but the bottom line is some 60% of all patients with lower stages of disease receive no radiotherapy now, as compared with in the past. And these excellent results have been maintained as well with reduced radiotherapy target volumes and doses. So in the past, treatment for a patient with nodes limited to the neck might well have been upper mantle radiotherapy and radiotherapy to the upper abdomen and spleen, with or without treatment to the pelvis, unlikely, but even so, a very large volume of the patient treated with radiotherapy. But now, when we do need to use radiotherapy, we often use very limited fields, limited to the area of the nodal involvement at diagnosis, and the fields are getting smaller and smaller over time. And the doses, too, have been reduced significantly by more than half, actually, with maintained excellent overall results. This is just an example of the kinds of fields that we might use now compared with what we might have used in the past. This is a PET scan showing very extensive disease in the neck, both sides of the neck and supraclavicular region, and in the mediastinum. An excellent response to just 2 cycles of chemotherapy, and a target volume that is much smaller than we would have used in the past. And this has been done within the clinical trials groups. And so we've been able to see which patients, to determine which patients do not need radiotherapy. We've also been able to reduce the volume and dose. And the clinical trials group also offer quality assurance for the treatment delivered, and also have allowed us to investigate the role of PET scans in patients with Hodgkin's disease, the kind of thing that could not have been done by single institutions. The treatment of medulloblastoma is also a classical situation where the clinical trials groups, treatment within clinical trials has really changed practice, in fact, and over a relatively short period of time. Medulloblastoma is one of the more common childhood CNS tumors. About 2/3 of patients have what we call average risk disease, so they've had a complete or almost complete resection, and they don't have any evidence of spread. And until the 1990s, so until relatively recently, treatment would have consisted of surgery followed by radiotherapy. This would have been craniospinal radiotherapy, so to the whole brain and the whole spine, to a dose of 35 to 36 gray. And this would be followed by a boost to the whole posterior fossa to approximately 55 gray. The outcome was very well established. The long-term survival was approximately 60 to 65% of patients, and the sequelae of treatment were also very predictable. It was common to see endocrine deficits, both thyroid deficiency, growth hormone deficiency, effects on growth and musculoskeletal development, and importantly, too, very importantly, effects on learning ability and academic performance, with predictable IQ losses that were quite important, particularly in the younger patients, but were also seen in older patients. So any alternative approaches were obviously the justification for looking at alternative approaches were to improve tumor control, because 60 to 65% is not, in fact, very good in pediatrics, and also to reduce the morbidity of treatment. So alternatives could have been alternative radiotherapy approaches or changes in radiotherapy volume or dose given in combination with chemotherapy. The children's oncology group, as did SIOP, looked at reduced dose craniospinal radiotherapy. So a dose, rather than 35 to 36 gray, a dose about 2/3 of that, 23 gray, followed by the same dose to the posterior fossa as we would have used in the past. But this reduced dose of radiotherapy was associated with significantly inferior survivals, with more relapses and worse overall survival. So this is clearly not acceptable. But within the groups, we also showed, again, as I say, over a relatively short period of time, that this reduced dose of radiotherapy is feasible if it's combined with adjuvant chemotherapy. And this is a study that was done in the late 1990s. This is a children's oncology group study that was published in 2006. And what we saw is that more than 80% of patients were now surviving event-free at 3 years and beyond. There was a minor difference in the two arms between the chemotherapy regimen used, but the radiotherapy was standard. And this was better than radiotherapy alone to higher doses, and significantly better than radiotherapy alone to reduced doses. So what we showed then is that we could produce very good survival using reduced dose radiotherapy with chemotherapy. And this study really confirmed for us, in North America at least, that reduced dose craniospinal radiotherapy and chemotherapy should be the new standard of care against which other regimens could be tested. And the next study that followed that was a radiotherapy study looking at further reduction of radiotherapy dose for craniospinal radiotherapy and reduction of the radiotherapy target volume for the boost. I'm not going to go through the details of this study, but patients would have their surgery first, followed by radiotherapy, which would be given along with chemotherapy with vincristine, and then went on to adjuvant chemotherapy following completion of radiotherapy. But as I said, it was a radiotherapy study where younger children from 3 to 7 years of age were randomized to either 18-gray craniospinal radiotherapy or 23.4-gray craniospinal radiotherapy with the same dose to the posterior fossa. But there was the second randomization in this group, and the randomization in this group was to whole posterior fossa radiotherapy versus a more limited radiotherapy field. And this is important because if we look, this would have been a pretty standard field in the past with lateral opposed fields where both where the treatment volume is actually here, but we're giving a significant dose of radiation to supratentorial brain that does not need to be included in the radiotherapy field. So by reducing the volume to the tumor bed rather than treating the whole posterior fossa, we could significantly reduce the amount of brain that didn't need to be in the radiation field, and also decrease the dose to other structures and reduce the risks, for example, of endocrinopathies secondary to radiotherapy or even hearing loss. So the endpoints for this study, there were stopping rules during the study, although the study completed accrual as planned, but a study like that had to have stopping rules for excess failure in the neuraxis because of the lower dose to the craniospinal axis, and for excess failure in the posterior fossa outside the tumor bed because of the reduced volume to the tumor bed. And the endpoints were, as you can see here. And my point is really that, you know, the survival rates have been improving, all the while using radiotherapy less frequently or only in situations where we know that we really need to use it now. And there have also been significant decreases in radiotherapy target volumes and doses, so that the long-term risks should be significantly less than we saw in that graph I showed you earlier on with patients treated 20 or 30 years ago. And the national and international pediatric cooperative groups have really played a critical role by ensuring that all of these changes were very carefully monitored and evaluated. So progress specific to radiotherapy then. There's one important consideration, and we heard a lot about that today as well from Helen, but there's been significantly improved preparation for treatment with much more comfortable and better immobilization techniques. I would say that we more routinely use anesthesia in very young children, but we more often, not every center, but more often have play therapists and others available to us to try not to use anesthesia if it can be avoided. But the bottom result, the end result, is a more precise and reproducible and safer treatment. And then specific to treatment, there has been significant improvements in imaging and co-registration tools for treatment planning, in radiotherapy treatment planning and delivery techniques. And also, I would say, better radiotherapy also as a result of participation in cooperative group studies, because not only are our treatment plans reviewed in real time, but there are online guidelines as to how to best treat patients, and there are educational programs that we participate in that overall improve the quality of treatment that's delivered. So the rest of my talk is really about what modern radiotherapy practice can offer pediatrics. And I'm going to focus on improved targeting and improved treatment delivery. There are some concerns about some of the newer techniques, and I will discuss those. So we've come a long way in terms of imaging available to us. You actually saw one of these films like this from Connor this morning, the neurosurgeon. I mean, it's not so very long ago that we had only very primitive tools for treatment planning. And even with the advent of CT scanning, when we still had to manually transfer data, there were a lot of uncertainties. And uncertainties usually mean that you end up using larger margins and include more normal tissue in the radiotherapy field. I'm older than Yen, so the pivotal point for me and for, I think, for radiotherapy practice was really the introduction of CT simulation in the early 1990s. I certainly agree that co-registration tools were very important, but this was really the pivotal moment. And now we incorporate as well functional imaging in treatment planning. For improved targeting, I would just use craniospinal radiation as an example. It's something that's used more in pediatric practice than in adult practice. And even so, it's only used a few times each year, even in busy radiotherapy departments, and it's a very complex technique. And what we know is that in the past, for a long time, we've known that targeting deviations happen, and they have been correlated with worse outcomes. And when we start reducing the dose, we have to make even more sure that the target volume is adequately covered. So the treatment volume, as I said earlier, would have been the whole brain and the whole spinal cord. The problem areas were in the front of, over the frontal lobe, over the inferior surface of the frontal lobe, where we might have tried to reduce the margins, or at least keep the margins tight because of a wish to avoid including the eyes in the radiation field. The other problematic area was at the bottom of the thecal sac here. And what happens if you don't adequately cover the frontal region, you get recurrences just like this. So with the introduction of CT simulation in the early 1990s, we can more accurately define the target volume in the frontal region. We can make sure that we're adequately covering the frontal region, and hopefully recurrences will be less frequent than is seen in the past. But indeed, MRI plays an important role, and using MRI in craniospinal radiotherapy helps us identify extensions of CSF fluid that we might not have included in a radiation field before, and helps us to define the limits of the spinal cord field, both the lateral extent that we need to cover and the lower limit of the field. And why is this important? Well, of course, I said earlier, I mean, we need to be sure that we're covering all of of the target volume in order to reduce the risk of a miss and recurrence in that area. And there's a real feeling, there's a belief that improved radiotherapy technique may have contributed at least partially to improved survival in patients with medulloblastoma. It's certainly not the whole story, but treatment techniques are much better than they were just a few years ago. And then attention to the width and lower limit of the spine field can allow us to reduce significantly the doses to organs that don't need to be in the radiation field, such as the heart and lungs and ovaries in girls. I said earlier, too, that we also now often use functional imaging. Again, Hodgkin's disease is a good example where PET scanning shows us very clearly the extent of tumor and allows us to much better target, to define the target for radiotherapy treatment. It can also show us unexpected or undetected, otherwise undetected areas of involvement in other sites. And in fact, it's been shown that as many as 70% of patients will have a change in radiotherapy volume as a result of PET scanning. Either the blue columns are fields that are actually extended, and the purple ones are fields that are actually reduced. But it's been said that PET CT scan is now essential in order to define. So I said CT scanning was essential before, and now I'm saying as well that PET scanning is essential for some patients. So then, to summarize what I've said so far, optimal preparation for treatment is absolutely crucial. Immobilization for sure for comfort, but also to ensure reproducibility over the course of treatment that you heard earlier. It can last as long as 6 weeks. CT simulation is routine now, and we add additional information as needed, such as with MRI, such as with PET scanning. And often, too, we need to talk with or even sit with, in front of the planning computer, the surgeon, the neurosurgeon, or the surgeon who operated on a chest wall tumor or other, who can be very helpful in helping us define the limits of the radiation field. And we're much better at more precisely defining the target volume and also of the organs at risk, and we increasingly use standardized guidelines for that. So in terms of improved delivery techniques, again, this really came with the introduction of CT simulation in the early 1990s and improved systems for treatment planning and delivery. And the end result is that, and again, Yen showed you that today, we're much better at treating the tumor more conformally with less exposure of uninvolved tissues that we don't need to include in the radiation field. This would allow us to, this would lead to a lower risk of normal tissue damage secondary to radiotherapy, and also the possibility, if you have less side effects, you can think, or less normal tissue in the radiation field, you can think about the possibility of dose escalation. This is not necessarily a consideration in the pediatric population, although it may be in some circumstances, but it certainly is in adult radiotherapy. Since then, there have been major developments in many different areas, and I'm going to go through most of these today, but they all have the same common goals: to improve the dose distribution to the tumor and reduce the dose to non-target tissue. Brachytherapy, I'm afraid you're not going to see this very well, but brachytherapy is not a new technique. This is a technique where catheters are loaded, implanted into the body tissues or into the body cavities, and then loaded with active seeds. And there's a very rapid dose fall-off around the seeds, and this has been described as the ultimate conformal treatment. And it can be extremely useful, such as in this 2-year-old boy with a perianal rhabdomyosarcoma, where we were really able to avoid treating a large volume of tissue unnecessarily and to significantly avoid including pelvic bones, for example, in the radiation field. So it's not something that's useful or used in the majority of patients, far from it, but it's something that should be available, and it can be very useful, as I said, in selected situations. Radiosurgery is also not new. You can see here, this is a very old picture, and you heard a little bit about that this morning too. We're talking about a technique that allows for a highly conformal dose distribution, a very rapid dose fall-off beyond the target volume. And typically, this technique has been used to deliver either a single or a few larger than conventional fractions. There are many ways that this can be done. This is a linear accelerator-based technique that we developed in the 1980s and used for quite a number of years, actually. You have a frame that's attached to the head of the patient with pins that you can see here. The frame is attached to the tabletop of the linear accelerator. And in this particular technique, both the machine and the treatment table rotate during treatment, so that you end up with a very nice dose distribution. So what's new here, and in fact, patients didn't mind too much. This is a little boy who was treated with that technique, and the frame was left in place for several days because he had a fractionated treatment. But what's new now is that we use removable frames, or even, again, as was mentioned this morning, frameless systems such as the CyberKnife robotic delivery techniques. There's not a huge experience with radiosurgery or stereotactic radiotherapy in pediatric practice, but it has been used. It is used in some selected patients with low-grade astrocytoma or craniopharyngioma, and it can be very useful for a boost. For example, in this patient, a baby with an anaplastic ependymoma who had residual disease following surgery, initial surgery, and had progressive disease during chemotherapy that was given to try to avoid or delay the use of radiotherapy. And this was a boost that was delivered following more conventional treatment, and was very successful in that the tumor was controlled in that location. So it's a way of delivering a high dose with a very rapid fall-off and sparing structures such as the brainstem, critical structures. What's also new is the use of stereotactic radiotherapy for extracranial sites. Again, not very much used in pediatric practice, but it could be useful. It's used for lesions in the lung, as you can see here, or in the liver, or in bone, again, with very rapid fall-offs and good sparing of vital structures. So something that should be available, might be useful, but again, would be used in only a very small percentage of all cases. The other major development in terms of delivery is intensity modulated radiotherapy. You saw some of that today too. This has really taken off since the early 2000s. The difference here, and again you saw that earlier, is that this is a patient treated with a very conventional technique where to treat the pelvic nodes. As you can see here, the treatment fields come in from 4 different directions and treat a block of tissue, including tissue in the midline here that really does not need to be treated. There's no reason for that to be treated. So now with intensity modulated radiotherapy, we start with the target that we need to treat, and the treatment planning system shows us how we can best do that, how best to deliver the dose that we need to deliver to the target and avoid unnecessary radiation to other organs. This is done because of with modern linear accelerators that have multi-leaf collimators in the head of the machine that move during treatment and end up, according to the definition I showed you a couple of slides ago, with a non-uniform distribution. And IMRT has significant advantages in terms of an improved dose distribution for an irregularly shaped target, improved possibility of sparing critical structures, and the possibility of delivering differential doses within the treated volume. And I'm going to show you some examples of this. So, for example, in a 14-year-old patient with a nasopharyngeal cancer, where we wanted to spare the parotid glands, we actually did a very good job of sparing both the parotid glands and the mouth. In a patient with, this was actually a dosimetry study where we compared IMRT with 3D conformal radiotherapy and stereotactic radiotherapy planned with a brain lab system, and we're able to show better orbital bone sparing and better sparing of the brain with IMRT compared with either of those other techniques. IMRT allows you to escalate the doses to part of the target volume. So, for example, in this patient, we want to deliver a higher dose to the tumor bed and the walls of the cavity where he had residual tumor, and a lower dose concurrently to the surrounding brain that needed to be treated because it's potentially involved, but perhaps not to the same dose. This is a patient who had an ependymoma with extensive, many seeds along the spinal axis and in the brain, multiple lesions at multiple sites. And in fact, this patient was treated with tomotherapy, again with differential doses. So the dose per fraction in the total dose to the red areas was greater than to the rest of the craniospinal axis. And the patient has disease control now, in fact, 3 or 4 years following treatment, if not a bit longer now. So something that really wasn't possible with older techniques. IMRT also allows you to dose reduce for part of the treatment. This is a young girl who was treated she was just 3 when she was treated with a low-dose craniospinal radiotherapy and a conformal boost to the tumor bed. And she failed with a solitary metastasis S1 on the spinal roots. And after much discussion and deliberation, we, with the parents' input actually, opted to retreat her with craniospinal radiotherapy, sparing the area, or with relative sparing of the area that had already received full dose. And again, this patient is very well a number of years later, something that just was not possible before. But there are concerns about the use of IMRT. Again, you heard a little bit about that this morning. There is an increased volume of tissue exposed to low-dose irradiation because of the use of a larger number of beams and increased beam on time for treatment delivery. And why is that important? Well, because low-dose exposure may be associated with an increased risk of secondary cancers compared with older techniques. And this was estimated by Eric Hall at the beginning of the 2000s as an almost doubling in risk. This was for adult patients, and at 10 years following treatment, the risk was estimated to be 1.75% rather than 1% at 10 years. But the risk is considerably greater than that. In other words, the relative risk is considerably greater in children than in adults. And despite that, though, IMRT has been used increasingly in pediatric patients. This just shows you the number of articles on IMRT in pediatrics, in pediatric practice. So this is a widely used technique. And the fact of the matter is many factors need to be considered when you're deciding on the optimal treatment technique. Younger patients and females are at greater risk for second malignancies. The location of the tumor is important, the size of the target volume, and very important to the delivery technique. And the other consideration is what are the risks, what are the competing risks? This is one risk, but what about other risks? Because IMRT allows you to significantly reduce high-dose exposure to to organs at risk. For example, this is a standard technique using a posterior field where you get often as much as 50% dose to the anterior structures. With tomotherapy, this was an IMRT plan with tomotherapy, we can show a significant reduction in high-dose exposure to the thyroid and the neck, to the lungs, to the heart, to the liver, to the kidneys, and to the ovaries, and to any structures anterior to the target. And this is a way that we can look at the doses and compare different treatment techniques. And this just illustrates what I showed you, what I told you just now. So we can significantly reduce high-dose exposure, but this is at the expense of some low-dose exposure here. The actual amount of the additional low-dose exposure is not that great, but there is an increase. The biggest difference really was the shift from 2D treatment to 3D. So increased precision using CT scanning already allowed for significant reduction in the dose to the whole body. IMRT only adds a little bit to that, in fact. So the integral dose was better than with 2D techniques, older 2D techniques, and only slightly greater than 3D. And as I said earlier, the dose to all other organs was less than with 3D CRT. So it's a reasonable option for many patients, but there's a lot we need to know about the effects of the long-term effects of low-dose exposure to a larger volume of tissue. And what comes up as a discussion point is, how do we discuss and weigh up the risks with the parents, and how can parents possibly be expected to choose? This is a very interesting study on informed consent in pediatric radiation oncology practice. That it was initiated by Karen Goddard and the group in BC in Canada, but with input from radiation oncologists who were present at one of the PROS meetings, one in Montreal, and at a PSYOP meeting later. And what she showed is that pediatric radiation oncologists were quite good at describing important late effects, such as effects on neurocognitive function, on hearing, for example, even on the risk of second malignancy, and infertility. But for other less well described or less clear long-term risks, we were not nearly as good at informing parents about those. And the majority of radiation oncologists, even ones who've been doing this for a long time, found this a very stressful process. And what's important to note, too, we've really not in the past ever had to discuss details of radiotherapy and weigh up the kind of things I was just showing you earlier. This is another table out of the same publication. And I think the bottom line is, there's a lot of conflicting statements here. I won't read them, but we're talking here about the need for full disclosure. But then on the other hand, that full disclosure is really impossible. Do we want to burden parents? There are a lot of questions. Well, the bottom line is it's very difficult. We need decision aids for making treatment. Even the healthcare practitioners need decision aids. There's a model that, for example, looks at life years lost, but how appropriate that is that when we're talking with parents, and what other aids might we come up with? So I want to move on now to talk about what's new or what's coming along in targeting. We have much better anatomical imaging with the MRI. We can incorporate now functional data in order to, which would allow us to selectively avoid certain parts of organs. And also now we can start thinking about biology-driven targeting. So, for example, this is a how-to guide for adult patients receiving whole brain radiotherapy for brain metastases, and a way of excluding the hippocampal region from the radiation field, because of the association with long-term neurocognitive effects even in adult populations. So this is something that's possible now, and something that is often considered now in pediatric practice, not for brain metastases, but for treatment of brain tumors. The neurosurgeons do very well now planning their trajectory for brain tumor surgery. We use the same kind of technology that they do, and there's really no reason to think that we can't start avoiding specific tracts or specific particularly sensitive areas of the brain. But to do that, we really need to know more about priorities and dose response to these to treatment. Biology-driven targeting, such as the use of PET, allows us to clarify uncertainties. This is a patient with a sarcoma with abnormality that's quite extensive, and it's hard to know what this is. But when we see the PET scan, we can see that one part of the tumor is much more biologically active than other areas. So this helps us to both to define our target volumes, but also in theory would allow us to give give a higher dose to a more biologically active component of a tumor. In terms of treatment, we're now talking about adaptive radiotherapy and the new modalities that we talked about earlier as well today. Image-guided radiotherapy is also here to stay. What this allows us to do, what it means is that daily setup is verified by using often CT scan these days taken on the treatment unit to precisely localize the target so that we can use much tighter margins than we would have considered possible in the past. And this will can result in significant normal tissue sparing. IGRT also allows us to document the dose delivered so that we take a cone beam CT on the day of treatment and we register this with the planning CT and we accumulate the dose so that at the end we know exactly what dose was delivered. We've done that, for example, with craniospinal radiotherapy, which has been very useful. This is also a very interesting case where we used IGRT to monitor treatment. This is a 15-month-old baby boy who had ALL, who presented at age 7 months with skin nodule involvement that never completely cleared and then recurred very rapidly after induction chemotherapy. So the plan for him was a stem cell transplant, amazingly enough, using his 3-year-old brother's stored cord blood that came out of the system that's used to identify matches as the perfect match. And so the challenge for us was to consider giving a boost to the whole skin surface prior to the conditioning regimen. So we used tomotherapy to do that. And we monitored treatment by recalculating the dose every day. What we found was not surprising, some underdosage and some overdosage of the skin. But what we were reassured about, and this is really why we did it, is that the organ doses were as planned. And this was important because the patient went on to total body radiotherapy after that. So we needed to know what the lung dose was and the kidney dose was and so on. IGRT also allows us to adapt the radiotherapy during the course of treatment in response to changes in either the patient anatomy or changes in the tumor size or shape. This is a series of patients treated at our institution for myxoid liposarcomas, which characteristically change. They're one of the few sarcomas that actually decrease significantly in volume during treatment and sometimes have no residual tumor at the time of surgery following preoperative radiotherapy. And so what we were able to do is, with using IGRT, is to adapt the radiotherapy so that we make sure that the tumor is adequately covered, if a tumor increases in size, for example. But in a case like this, we were able to actually reduce the target volume and reduce the amount of normal tissue in the radiation field. In the future, I put a question mark here, but I think that there's no doubt that in future, adaptive radiotherapy will also be based on the biology of the tumor and molecular changes occurring during radiotherapy. Proton therapy we heard about today, the major advantage being the lack of dose beyond the Bragg peak. There is some entrance dose as we saw today, but less than we would see with conventional treatment. And we've seen this today too. In craniospinal radiotherapy, this is a treatment delivered with tomotherapy. Proton therapy would allow a significant, much greater sparing of structures anterior to the target. The problem is that proton therapy is expensive and not widely available, and some governments, such as our own, the Quebec government, feels that proof of benefit is not yet available, and therefore that they do not need to provide it for now to all patients. So what we did, what we have done is we have undertaken a planning study where we collected all patients treated over a 6-month period in Quebec with a population of about 7.7 million. And the objective was to compare the best photon plan with intensity modulated proton therapy. And we looked at models that are available in the literature and looked at the secondary cancer risk the risk of secondary cancer after craniospinal radiotherapy. And the bottom line is that although some patients benefit from treatment, not all patients benefit, and not all patients could be expected to benefit to the same extent. We also looked at proton therapy for the treatment of Hodgkin lymphoma, and there what we were looking at was the dose to the heart. Again, the message was the same. Some patients, not all patients benefit, and not all patients benefited to the same extent. So the plan would be for our patient population, covering a large area in Quebec and in the eastern provinces of Canada, we would expect to plan patients at their center where they were seen initially to determine the potential benefits, and with the goal to ensure appropriate referral for proton therapy and avoid some of the stresses and the expenses if there's the likelihood of gain is not great. So I would say that, I think we're all excited about what's been happening in radiotherapy over the last 10, 15, 20 years, but we still have a great deal to learn. I think that we need to work very closely with the with the other people involved in the care of these patients, both to plan the overall management strategy, but also within our departments to ensure that we're using the best possible radiotherapy treatment planning and delivery systems. We really don't, there are still many unknowns. The risks of the treatment that we use now hopefully should be less than treatment protocols used in the past, because we're using smaller radiotherapy volumes, we're using more conformal techniques, we're using lower doses. We're also using, I didn't talk about this at all, but we're using, typically we're using lower energy beams, so with less risk of whole body exposure from neutron contamination of the but they could be greater because of the low-dose exposure, either due to the IMRT or to the image-guided radiotherapy or because of the more aggressive chemotherapy regimens. Proton therapy is very likely to be associated with lower risk for some or even the majority of patients, but it's not established yet. What we need to do is we need to work together to collect all the clinical and radiotherapy data to accurately document long-term effects of treatment. And we need biological material for biomarker studies to try to predict which patients are at greater risk and what they're at risk for. And this has to be done in a multi-center approach because of the small number of cases. And it has to be done with long-term follow-up because, as I showed you on one of those very first slides, the radiotherapy effects don't plateau. So in the meantime, we need to follow up our patients very closely. We need to educate them about risks and about maintaining a healthy lifestyle. We need to make sure that they are seen on a regular basis for a regular physical exam. And we need to make sure that they are part of screening programs and starting at a younger age than recommended for the general population. And the reason is, of course, because we want to ensure timely diagnosis and intervention of secondary health problems. So I want to just finish by thanking my colleagues in the departments of radiation oncology and medical physics at my institution. And I am actually a Westminster graduate. And I was asking for a picture of Westminster Hospital, and I was told to look in Lost Hospitals of London. So that's where I came from. This is where I spent most of my time, in the very beautiful city of Montreal. And this is our new radiotherapy department and the research building right next door. So thank you very much.